Okay, so hopefully that was not too bad and that you enjoyed reading the article that I sent. It's an awesome article. They talk a little bit more about stuff, and we're going to talk a little bit about some of the concept of this thing. Breathing. So we talk about airway. We talk that, like sometimes some people will need to have their airway breathing. That doesn't mean a tube, and sometimes we'll need a tube, but doesn't mean that it's an ET tube. It could be a supraglottic device. It can be NPAs. It could be OPAs. The other thing too, around when we attack the breathing problem, is a lot of people sometimes confuse two things: oxygenation and ventilation. And it's in my head, I like things to be like kind of algorithmic kind of stuff, and I like it to approach it this way, and I'll tell you why. So let's go with that. So oxygenation and ventilation. So get someone coming. Let's say here, two patients come. One is 20-year-old. Both are 40-year-old. One's been coughing green stuff since for 4 days. Fever, chills, coughing, very wet cough. SAT, because everybody loves a SAT. We'll talk about that. Just put that up a little bit more now. And we'll come back to it. There we go. So SAT of, there we go. Let's make it bad. 90%. So patient A, 90%, he's coughing 4 or 5 days, and both the patients that we'll see are 40-year-olds and stuff. Patient B thought that it would be cool to play with his nephew and stuff, went to a party, not sure what he took, but breathing 4 a minute. And decreased level of consciousness. Took something, we're not quite sure what it is, but breathing about 4 minutes and stuff. Both has a SAT of 90%. So they have low SATs. Which one would you give oxygen? And probably I already hear that both of them you would give oxygen. Both SAT goes up. Let's say this one up to 90. Let's say this one 95%, and this one, oh, you got lucky, 100% because you put another breather mask. Which one have you helped, and which one didn't you help? Because there's a patient there that you didn't do exactly what he needed. And hopefully, most of you are starting to notice that in B there's missing something. What is it missing? And that's where we're going to go back to oxygenation issue versus ventilation issue. Oxygenation. How does our oxygen goes from the air outside to our alveoli, or actually to our capillaries? So basically what happens is that you have your alveoli over here, and by pressure it diffuses. It's a diffusion process. Nothing. So if I paralyze you right now, I wouldn't do it, but if I paralyze you right now, you can still have oxygen in your body for about, depending on the side of your lungs and stuff, let's say for 5 to 6 minutes, because it's a diffusion process. So all the oxygen that was there, depending on how big of a breath I had and everything, is still there, diffusing through my system. And my SAT, the only thing that I'm calculating how many trucks I have, and we'll talk a little bit about the limitation of SAT. Problem with ventilation. So oxygenation is a question of O2. Ventilation is a question of CO2. The problem with CO2, SAT do not assess CO2. Entitled CO2 does, but SAT do not check that. So if I'm monitoring someone with a ventilation issue with a SAT, you can see the issue here is that my oxygen can be normal, and this is what was happening in patient B by diffusion, because I put a non-rebreather mask, which is about 90% oxygen, and let's say this person doesn't have any respiratory issue, no lungs issue and everything. I'm increasing the pressure in the alveoli of the oxygen, but I'm not solving his issue of end-tidal, which is because he's breathing at 4 a minute. So the oxygen goes in, but the end-tidal doesn't go out, because CO2 needs a mechanical way of getting out in your body. And the mechanical way, it's called the diaphragm working. So going down, going up, going down, going up. So it's related to my respiratory rate. If I can blow, and that's why, for example, you'll see somebody that wants to blow CO2 will breathe rapidly to try to compensate, for example, for metabolic acidosis. We'll try to decrease their end-tidal CO2. How are they going to do that? They're going to breathe fast. Why? Because they blow more CO2. CO2 comes out, goes down. It goes down in their body because there's more coming out of the body. So my end-tidal CO2 monitor my ventilation issues. And if I put oxygen, and how many people do we see, for example, they come, decreased level of consciousness, not breathing very well, we put a non-rebreather on them and suddenly we're like, oh, it's all good. Well, no, we need to monitor the respiratory rate. So, what do we need to check out for people from O2 versus CO2? The CO2, respiratory rate, the end-tidal CO2 could be a very useful form over here. Here we'll use as a SAT, but the SAT again, let's talk a little bit about the SAT for a few minutes. The problem with the SAT is that it has a lot of limitation to it. So for example, if I'm cool extremities, my SAT won't read properly. And my SAT also just check how many trucks I have carrying some oxygen. So if I have 10 trucks, so imagine that now, for example, I have someone that just bled for whatever reason, like a low GI bleed, and my hemoglobin is 50. I can still have a normal SAT, or normal SAT. So basically I could stay in the 90, 95. Why? Because all of the SAT looks is that the trucks that are passing by, do they have 4 people inside? So they're like minivans. So there is 4 people inside. I see it, I'm at my desk, I see a truck passing. Yeah, 4 people, good. 4 people, good. 4 people, good. And I count how many people out of the. So if there's 5 out of the 5 truck that pass, that's almost 100%. So that means I would have a normal SAT. The problem is that if I go from my example, I got a hemoglobin of 100, which would be 400 people, versus a hemoglobin of 50, that would be 20 transporter of oxygen versus 400. That's a big difference. So that means my oxygenation may not be very well in my body, but yet my SAT could probably tell me. So there's one limitation of the SAT. As well as the SAT has another limitation is that what they call the SAT lag. And one of the articles that I showed in the other one was explaining it. Basically, up to 30 seconds in a normal person, you can have the SAT kind of talking like this. We'll show you the numbers. And up to a minute and a half in sometimes in very sick patients. So SAT has like his limitation. Entitled CO2 is a little bit more boom boom, like right there stuff. It also has its limitation, but a lot of people give bad press to this, and yet it is a very useful tool. Because of this, we can monitor the CO2. So for example, if I have an asthmatic, I don't really care so much about their SAT. I want to know that their CO2 is raising. The number is not accurate, I will give you that, because a lot of time the entitled CO2 is not great. But if I go from 40 to 60, I don't really need to know the true numbers of my patient. What I just saw here is a trend from 40 to 60. This patient is getting sicker because it's getting tired and he cannot expose his CO2 because now there's more CO2 in his body that is read by the machine. So that's why the trend of the end-tidal CO2 is as good as the number. I don't care about the number so much as the trend about it. Just like blood pressure, it's not one number doesn't tell me much. It's about the trend. If my pressure is going up or my pressure is going down, it tells me something. But the pressure itself, one number, doesn't mean much. But the trend of the end-tidal CO2 can tell me. So in your breathing issues, you can always put them in a category. And it's very important to ask yourself which category they are in, because some things that we're going to do will help. So for example, if I'm giving oxygen for my my oxygenation issue, yeah, good, yay. So for example, if I have a pneumonia that has a problem with diffusion, by increasing the pressure in the alveoli, well, hopefully some of it will transfer a little bit more because I have a little bit more oxygen there to exchange. But if I have someone that basically, like I was talking about, is had an overdose or something, it's not breathing properly, even giving oxygen won't help me. I need to empty the oxygen, the CO2, sorry. And for that, I need a mechanical movements to happen this. So this one basically needs a bag, or even mechanical ventilation for a little while until the drug goes away. But for now, needs a bag, doesn't need oxygen, needs a bag, needs to be bagged. Versus this one needs oxygen, and oxygen alone can work. If you get into the ventilator issue, you can have the PEEP will be one of the setting on the ventilator that will affect the oxygen basically, because it will open up the alveoli and push. If you have fluid, you can imagine, let's say I have that much fluid, the PEEP, what it's going to do is going to kind of push that fluid away and decrease that space. So instead of having that much that the oxygen has to traverse, it has maybe that much, and it helps for the stress. So the PEEP will help at a ventilation, at an oxygenation issue and a ventilator. For the CO2 would be the respiratory rate, will be very important. But another one that can also add is the tidal volume, because smaller volume or bigger volume, if I can play with those two, will give basically, it's not so much my tidal volume but my minute volume. And two of the things that plays with the minute volume is my tidal volume, because minute volume is tidal volume by respiratory rate. So if for example, I got someone with bad lungs, or for whatever reason I cannot play too much with my tidal volume, I'll play with my respiratory rate. But what's important is to make a minute volume that is sufficient to liberate those end-tidals, that CO2, which that's why my end-tidal CO2 becomes very important over here. And somebody that has a problem like we were talking about, like overdose, and obviously there's other issues that with the ventilation, then I'll be bagging this person as well. Just putting oxygen on it, it doesn't matter, and yet it's something that we see a lot. You know, somebody comes, we put a non-rebreather, and we almost forget about them. But always, all the disease, you ask yourself about the physiology of it. Is it a problem with the oxygen, or is it a problem with the ventilation? So, for example, pneumonia, CHF, more problem with the oxygen because the diffusion doesn't happen. That's why also, for example, here, because the PEEP is important, a machine like the BiPAP, the CPAP, will work, because what it does is it creates this pressure in your alveoli, which helps the transfer of oxygen and everything. If I would put, for example, this BiPAP or CPAP on someone with an overdose or something, it wouldn't work because it's mechanical. I need to breathe for them. I don't need to push the air more on them. I need to breathe for them. So a ventilator would be better for those ones. But also asthmatic are kind of in this category initially, and then kind of go slowly to an oxygen issue because of their narrowing of their stuff. But mostly they're trying to get their CO2, and that's why it's a great, if you see their trend going up, then you kind of know that they have issues with this. So asthmatic is kind of like, that's why the literature is like, on the use of BiPAP machine and CPAP. For COPD, CHF, it's there, yes, use it, but for asthmatic, they're like, not so much. Anyway, I hope that this helped a little bit, and that I was not babbling too much. If you have any question, don't hesitate to send me a message. or text, and I put a link that I already sent on exercise for doing this, and we can go back through each patient if you want to.